Now we're going to go to our next speaker, who is Dr. Marc Judson. He is the chief of the Division of Pulmonary and Critical Care Medicine at Albany Medical College and the Cleveland Clinic. Let me just make a note that he and all the rest of our speakers are going to be doing their presentation. And then afterwards, there will be time for Q&A. So as I mentioned, you have to use the Q&A feature on Zoom. If you go to your screen and it says Q&A, that's at the bottom. That's where you're going to enter your information. So now let us now welcome Dr. Marc Judson. Marc, take it away.
Dr. Marc, you're still muted.
Thank you. Sorry.
No worries.
Thank you, Pam. I want to thank Pam and Paula and the SRI for the opportunity to speak. I've had the privilege of working with the Sarcoidosis Research Institute, the SRI, for at least 4 years, actually longer than that. And I just really appreciate the tremendous effort that they're making for sarcoidosis patients. So I'm going to share my screen, and let me share it here. And I was tasked with giving an overview today of sarcoidosis. And that's what I'll try to do over the next, hopefully 22 minutes, and leave some time for questions. Let's start with the history. Sarcoidosis was first discovered in 1869 by Dr. Hutchinson, who was a British doctor. He wasn't just a British doctor. He was known at the time as a brilliant clinician, probably the best doctor in all of England. And he had a patient named Mrs. Mortimer who had these strange skin lesions on her face and arms. And he called it Mortimer's malady, naming it after Miss Mortimer, the patient. And it was thought for the next 30 years, from 1869 to the end of the century, to be a skin disease. And that's because X-rays were not invented until about 1900. And once X-rays could be performed on patients, it was realized that sarcoidosis is not just a skin disease, it also is a lung disease, and in fact was soon thereafter found out that it's a disease that can affect any part of the body. And even into the 1930s and 40s and 50s, this is a graph of number of publications per year in the world that were done concerning sarcoidosis. And you can see even in the 30s, 40s, and 50s, even though we're now talking 80, 90 years after Dr. Hutchinson discovered the disease, there's very little medical publication on sarcoidosis. And I want to tell you a little personal story about that. This is a picture that's about 22 years old of me and my wife. This is when we were engaged. We went on a trip to Seaside, California, a beautiful little town. And in the middle column there at the bottom, you see a much younger me in front of this really cool coffee shop in Seaside, California. And this coffee shop had like a library where the community would come in and they could look at any books that they wanted in this library, which was right in the middle of the coffee shop. And there was this huge unabridged Webster's Dictionary from 1950. I mean, this book I've never seen a book this big. I don't even think I certainly couldn't pick it up with one hand. I don't even think I could pick it up with two hands because it was so wide. You have to kind of use my arms to pick it up. And this book supposedly contained every word in the English language, or just about, that was known in 1950. So of course, what did I do? I immediately went to see if sarcoidosis was in there, and it wasn't. So this just makes the point that even 70 years after sarcoidosis was discovered, it still was not a word really ever used in the English language. Well, now in the last 20 years, there's kind of been an explosion in our knowledge about sarcoidosis, although we have a long way to go. And in terms of where sarcoidosis is, it occurs all over the world. There are high rates in people of African descent. It has very high rates in Northern Europe. It's interesting that it is more common the farther you are away from the equator. It's more common in Northern Europe than Southern Europe, Northern Japan than Southern Japan. It's seen in men and women, but it's seen more frequently in women at a rate of not quite 2 to 1. And Black people seem to have disease at an earlier stage in life than white patients. A little bit of a complicated table, but it's trying to make the point, if you look at the red box and under the new cases, that about 80% of cases occur age 45 to over 65. We used to think of it as a young person's disease. It's actually a disease much more common in middle age and older age. Now, interestingly, in Black people, the disease does have an earlier onset, more commonly than whites, to occur in the 20s and 30s. But it's really a disease mainly in year 40 and older. And what is sarcoidosis? What is the disease? The disease causes lesions in the body. It can occur in any organ of the body. And what are these lesions? What happens in sarcoidosis is that white blood cells, which are supposed to be in blood vessels, the red blood cells and white blood cells should be floating in the blood vessels. But what happens in sarcoidosis is that some of these white cells actually leave the blood vessels and they go to various organs where they conglomerate together. They kind of fuse together to form these microscopic balls of white blood cells. And the medical term for these microscopic balls of white blood cells are granulomas. And on the left here, can you see these balls here? These balls are basically balls of the patient's own white blood cells, which left the blood vessel and went to some organ in the body, most commonly the lung, where they form these balls or granulomas. Now, why did these white blood cells leave the blood vessels and travel to these organs and form these granulomas? We don't know. The cause of sarcoidosis is not known. And in the picture on the right, you see an even higher power of these granulomas, of these collections, microscopic collections of white blood cells that have deposited in some tissue in a sarcoidosis patient's body. And these, again, I don't want to go get too technical, but these, you see this big, large little collection of cells is the cells actually can fuse together and form these conglomerated cells. But these are the lesions of sarcoidosis, and they most commonly occur in the lung, but it can occur in any organ in the body. Now, what's interesting about this is that we don't know. The question is, why are these white blood cells leaving the blood vessels and going to these organs? It might be because there's some substance which got in the body and the immune system is functioning normally. These white cells are trying to attack what got into the body and trying to clear this substance out of the body. In that case, the immune system would be normal. Another possibility, because again, we don't know why the white cells are doing this. These are just guesses that we have. Another possibility is that the immune system is abnormal, that it's attacking itself. And this is the concept of autoimmunity. A lot of patients say, well, they think that sarcoidosis is autoimmune. Well, we actually, in 2026, don't know that. It may be autoimmune if the immune system is abnormal and abnormally attacking itself, but the immune system may be fine. It may be attacking a foreign substance that's entering the body. So the bottom line is we don't know if these granulomas are formed because the body's immune system is functioning normally or it's functioning abnormally and just attacking itself. And in fact, not to complicate matters, doing research that is being done right now, most people think that actually both processes are involved in forming these balls of white blood cells, these granulomas. But the bottom line is today, we really don't know the answer to this question. Now, okay, so these granulomas, these collections of white blood cells of a sarcoidosis patient, these balls are forming in various organs. So they deposit in various organs, and they can deposit in the lung, the skin, the eye. These are the three most common organs: the lung, skin, and eye. In fact, there are very few sarcoidosis patients who don't have involvement of at least one of these three organs. Lung involvement often is handled well, medically or even without medication, but it can be fatal. It's commonly also, these granulomas deposit in lymph nodes of the body and the liver, but usually this is not serious. Even though you have to have the liver, you can't live without the liver. Usually in sarcoidosis, there aren't enough granulomas to cause many problems in the liver, although occasionally it can. Not that commonly, these granulomas, these balls of white blood cells, can deposit in the heart or the brain. And on occasion, that can be fatal, although usually it can be handled as well. So they can deposit in the lung. That's the most common organ that these granulomas go into. And you see here, again, I know you're not radiologists. This is what the lung should normally look like, this black area. You see these white cloudy areas? It shouldn't look like that. That's sarcoidosis in the lung. And that can cause the patient to have cough or wheezing or shortness of breath or sometimes some chest pain. Those are the common symptoms that lung sarcoidosis causes. And here's just a CT scan. And again, I don't even see these little white dots out here. These are all little granulomas, and they can coalesce into these big globs of granulomas in the lung. And it can deposit in the skin. And this lady gave me permission to use her slide in lectures. And you can see all these nodules and scarring on her nose. If you biopsy this and look in the microscope, you'll see these white blood cells, these granulomas, these balls of white blood cells that deposited in her skin. And sarcoidosis loves scar. If a sarcoidosis patient has a scar in their body, a scar is like fertilizer for these granulomas. I mean, not every patient with a scar with sarcoidosis has granulomas, but there's a bump on this sarcoidosis patient's scar. You can see the faint scar. And this little bump here, if you biopsy that, it's all full of granulomas that have grown on the scar. And sarcoidosis loves tattoos. I mean, tattoos are basically a scar. The guy who put on the tattoo gave you an artificial scar. And I have sarcoidosis patients who call me up and say, Dr. Judson, my sarcoid's getting worse. And I ask them, how do you know that? And they say, those bumps are coming back on my tattoo. So these, again, are manifestations of sarcoidosis as it's depositing in various organs. And it can deposit in the eye. And this is a very close-up of the cornea, the front of the eye. And you see these white globs here, these white spheres. These, again, are granulomas that are accumulating in the eye. Another very common organ involved with sarcoidosis, when granulomas go in the eye, they can cause a red eye, they can cause painful eyes, they can cause pain when a sarcoidosis patient is under bright lights. They can cause visual disturbances of all sorts. So this is another organ that can be involved. Sarcoidosis can involve the heart. And this is someone who unfortunately died of sarcoidosis. You see these white little spots. These are all granulomas that coalesced and deposited in the patient's heart, causing bad heart function that was ultimately fatal in this case. Sarcoidosis can occur in the brain. These little white spots here here are all granulomas depositing in the brain of a sarcoidosis patient. So this is how sarcoidosis causes problems. These granulomas, these white blood cells leave the blood vessel, they deposit in these organs, and that causes the patient to have problems because the organs don't work properly. But sarcoidosis can affect patients in other ways, which have only really been appreciated in the last 15 years. And that is, without the granulomas depositing in these organs, these granulomas, these balls of white blood cells, can produce chemicals that go throughout the body and cause problems, even without depositing in a specific organ. And we call this parasarcoidosis. And these are symptoms or dysfunction in sarcoidosis, not directly related to the granulomas depositing in an organ, but with the release of chemicals through the whole body, which do harmful things to patients. And there are many different kinds of parasarcoidosis syndromes, and here are some of them. I'm just going to point out some of them in the next few slides. This is a complicated slide, but the bottom line is these granulomas, these white cells, they secrete an enzyme which activates vitamin D. And when it activates vitamin D, it can raise the blood calcium, it can cause kidney stones and a very high blood calcium level, which is dangerous. And some sarcoidosis patients who are listening to this have probably had kidney stones from sarcoidosis and have had high blood calcium. And that's a parasarcoidosis syndrome, as these white blood cells are secreting chemicals to do this harmful thing. And another very common parasarcoidosis syndrome is small fiber neuropathy, which may occur in up to a quarter of sarcoidosis patients. And what happens here is that nerves in the skin get damaged by these chemicals secreted by the granulomas, and they can cause a painful neuropathy, which is often an electric shock sensation in some part of the body, or a burning sensation. And it can be patchy in various areas around the body. And it can also cause autonomic nerves. These are other special nerves in the body to be affected. And this can cause sweating. Some sarcoidosis patients have excessive sweating. I have some sarcoidosis patients who have a high heart rate all the time. This is probably another one of these syndromes stimulated by secretions, by these white cells spewing out chemicals throughout the body. And this is a small fiber neuropathy again. This is, I said, these nerves in the skin get damaged. And this condition is diagnosed by a skin biopsy. This is a biopsy of the skin. And you see these little black strings here. These are nerves which are supposed to be in the skin. This is a normal patient. Here's a sarcoidosis patient with small fiber neuropathy. You don't see those black strands anymore. They've been destroyed, not by granulomas. There's nothing depositing here. These white cells are not, these balls of white blood cells are not depositing on these nerves, but just some chemicals that granulomas that are elsewhere in the sarcoidosis patient's body are producing are destroying these nerves and causing this small fiber neuropathy condition. So that's a little bit about what these granulomas, what sarcoidosis can do to a patient. How do we treat it? Well, there's basically two reasons to treat sarcoidosis. One is if the patient has significant quality of life impairment from the disease. And another reason to treat it is if there's a dangerous situation from sarcoidosis. Those are the two main reasons. We don't treat everyone with sarcoidosis. They really have to have a decrement, a serious decrement in their quality of life or have a situation of danger. Why don't we treat everybody with sarcoidosis? I mean, isn't that what we should do? Well, we don't do that for a few reasons. First of all, the treatment, especially prednisone and steroids, has a lot of toxicity. And in patients who don't have any symptoms, the treatment can be worse than the disease. The second reason not to treat is this, as shown in this slide here. In this study, the patients who were treated, 73% of them had relapse. That's the big bar on the left. And those who were not treated, less than 10% had relapse. So if you treat these patients, they have a higher rate of having a relapse. Now, why is that? We don't really know, but I think most people believe the reason is that the granuloma is actually probably, remember I said there may be some substance entering the body, and the granuloma is the body's attempt to try to control or destroy whatever entered the body. If you wipe out the granuloma, that substance is still in the body. So if you stop treatment, the granuloma may form again. The patient's white blood cells may go in again and cause it again. So this has caused a shift in how we think about sarcoidosis. And actually, if what I'm saying is true, the granuloma may actually be a good thing. It's trying to get rid of a substance that's entered the body that may be harmful. So you really should leave the granuloma alone, possibly. Let it try to destroy this substance that entered the body. Unless if the granulomas become too massive and you cause damage to an organ or the patient's quality of life is bad, then you have to come in and treat. And so that's our theory now. Just because someone has sarcoidosis, if it's not causing problems, we kind of leave them alone and don't give them steroids and bad medicines and see if the granulomas can control the condition and take care of it. But of course, many times the granulomas become too massive or cause quality of life impairment that we have to treat. And the drug of choice for sarcoidosis has been prednisone or steroids because it works almost all the time, virtually all the time, and also works faster than any other drug. But the side effects are very significant. And in fact, the quality of life often improves at first with prednisone or other steroids because it wipes out the granulomas. But then the quality of life actually worsens very often because of the steroid side effects. So yes, it's a great drug to treat sarcoidosis or dangerous sarcoidosis where you have to treat right away, but it has a lot of potentially bad side effects. And this is a slide I show my patients to let them know that, it's not a benign thing to give steroids. It can cause weight gain. It can cause high blood pressure, diabetes, cataracts, glaucoma, osteoporosis, increased risk of infection, change your mood, acne. I mean, it's a great drug for working for sarcoidosis, but it has a lot of serious side effects. And for that reason, recently, in the last several years, a lot of sarcoidosis experts have published a position paper really stressing that we need to move on from prednisone and develop more drugs. Now, we've been trying to develop more drugs for 20 years. It's not like we haven't been trying to do that, but we're trying to make a call to really put even a greater effort on this. And this quote is from that article, and I don't usually like to read slides that I put up, but I'm going to read this one. The overuse of oral corticosteroids in the short-term and long-term management of sarcoidosis should be viewed as a crisis. The concept of safe, low-dose oral corticosteroids like prednisone in the long-term treatment has now definitely been discredited. The initial oral corticosteroids continue to be required when there is severe major organ damage or when severe symptoms require rapid alleviation, but a second-line agent should be introduced, ideally at initial treatment to minimize steroid use. In other scenarios requiring treatment, alternatives to steroids should be considered, and in patients on long-term corticosteroids, immediate steroid withdrawal is a pivotal goal with replacement by alternative agents if necessary. Now, we haven't really reached this goal in total. It's a kind of forceful statement, and I still use steroids, but I think we're all on alert that we really should try to minimize it or get patients off whenever we can. We need to look for steroid-sparing drugs, which lower the dose of steroids that we need or ultimately get them off steroids. And there was a landmark paper last year. Last year was a big year in sarcoidosis because of this paper looking at methotrexate, which is a drug used in sarcoidosis, showing that at 6 months, we're looking here at change in the breathing function. In 6 months, the methotrexate was as good as prednisone. Now, methotrexate also has side effects, usually less than prednisone, and it takes much longer to work. Okay, so sometimes we start with prednisone and methotrexate at the same time, and then over time, we try to eliminate use of the prednisone. But at least it was clearly demonstrated that methotrexate is as good as prednisone if you wait at least 6 months. I'm looking at the clock, but I think we have enough time because I want to leave time for questions. There, basically, in terms of the prognosis of sarcoidosis, about 50% of patients have no symptoms ever, or the disease resolves in a year. About 30% of patients have chronic granulomas where they don't really cause major dangerous damage, but if you stop treating it, it tends to come back. And about 10 to 20% have dangerous disease, heart disease, brain disease, or severe fibrosis. So not extremely common, but 10 to 20% have really bad potential complications. So in summary, in this overview, sarcoidosis occurs all over the world. Any organ can be involved with sarcoidosis, the lung, skin, and eye most commonly. The most deaths are from lung, heart, or brain or nervous system involvement, although even in these groups, death isn't that common. And the disease is not just from depositing of granulomas in various organs, but there can be non-organ involvement from these parasarcoidosis syndromes where chemicals spewed out by these granulomas affect other areas of the body. The disease sarcoidosis involves the patient's own white blood cells. The patient's own white blood cells are causing the problem. Now, it's not known if they're doing this because they're stimulated by a foreign substance that it's trying to get rid of, or if the immune system is just not functioning properly and there's autoimmunity. We don't know which of those two is happening or if both are happening. And steroids are the most effective drug for sarcoidosis, but unfortunately, it very commonly causes side effects, which can be severe. And so we need to continue to search for alternative treatments for sarcoidosis. And with that, I'll thank you for your attention. And I think we have a few moments for questions.
Yes, thank you, Mark. Appreciate that. That's some great information. There was a question in the Q&A from someone who asked about if anyone with sarcoid has bone marrow suppression involvement. Are you aware of any information on that?
Yes, that's not an incredibly common manifestation, but you can get bone marrow involvement in sarcoidosis. That can cause an anemia, low blood cell count, or low white cell count, or even low platelet count. But also a lot of patients with sarcoidosis, some of the drugs, not prednisone, but like methotrexate and other drugs can also lower your blood counts. So those are the two main causes of blood counts being low in sarcoidosis.
Okay. Another question from the Q&A is for patients with lung sarcoidosis, is it potentially harmful to engage in high intensity exercise that causes severe shortness of breath, persistent coughing, or even vomiting?
I think it's important for sarcoidosis patients to try to do the best they can to stay active, but you don't want to bludgeon yourself. So I wouldn't, I would do what you can do. I think that's important for your health. But if you're doing some sort of workouts and you're just coming home exhausted, your body's telling you you're doing a little too much. So it's a fine line there. I do what you can, but know your limitations. And hopefully if you get treated, you'll be able to do more.
Okay. Another question from the Q&A. Are there dietary approaches that can help regulate inflammation by limiting the migration of white blood cells from blood vessels into the tissue?
Okay, that's a good question. And I think it brings up the bottom line is there is no diet that we know that is effective in sarcoidosis. But I think this is an important point. A lot of people talk about anti-inflammatory diets. When you talk about inflammation, it's like talking about, I don't know, do you have cancer? Well, is it lung cancer? Is it skin cancer? It makes a difference with your prognosis and everything. There's many different types of inflammation. And a lot of these anti-inflammatory diets, as far as I know, none of them works for granuloma. The granuloma is a type of inflammation. So the bottom line is these diets have never been shown to be effective for sarcoidosis, but I would just say live a healthy lifestyle. And I don't mind anyone trying anti-inflammatory diets unless they're so expensive you're getting ripped off, because I really don't think I think if you want to try it, that's fine, but just don't spend a lot of money because there's no evidence that they really work for sarcoidosis.
Okay. Another question. What percentage of sarcoid cases affect nerves?
All right, good question. Usually it's about 5% affect the nervous system. Most of it is the brain, some in the spinal cord, and some in the peripheral nerves of the body. We talked about the small fiber neuropathy. That's something different, but it can occur in all those places.
All right. What about gynecological conditions? Can any conditions like endometriosis or fibroids be associated with sarcoidosis, or sometimes be misdiagnosed when they're
Okay,
they're actually sarcoidosis?
The answer to that question is yes, but that's really rare. But it does happen. You can get it. It can grow in fibroids, and it can grow in any part of the female reproductive tract. But I've been practicing sarcoidosis for 30 plus years, and I've probably seen 5 to 10,000 patients. I have seen that about 10 times. So it's pretty rare, but it can happen.
Okay. Can a blood test determine how bad inflammation is with sarcoidosis?
Well, that's a really involved question, but I'll try to keep it short. There are some blood tests, they're not perfect, which can tell you how much granulomatous inflammation you have in your body, but there's not a great correlation between that and the need to treat patients. But there are blood tests available. They're not 100% accurate, which can give you an idea of how much sarcoid inflammation is being caused in your body.
Okay, now this is going to be one that tests my pronunciation skills here. You addressed methotrexate. What about azathioprine and infliximab slash Remicade or Remicade?
Yeah, okay. They're talking about azathioprine and infliximab, also known as Remicade. Yes, we show those drugs are also effective in sarcoidosis, and we do use them as well as a few others. But those drugs are being explored and are being used as well.
Okay. And I think maybe the one last question. How do you know what stage of sarcoidosis you're in and what's considered too late?
The staging system for sarcoidosis is kind of antiquated, and we really don't use that in patient care anymore. So we look at each patient more individually. And I think the main issue often in sarcoidosis is sometimes these granulomas that we talked about can cause scarring. And if they cause a lot of scarring, that's usually when we know the sarcoidosis condition is pretty advanced. But we really, I would say, don't really use that staging system anymore in assessment of sarcoidosis.
Yeah. Okay. Well, thank you so much, Dr. Judson, for that. We appreciate all the helpful information.